Good evening, everybody. Welcome to the latest edition of the Injury Rehab Network Northwest, brought to you by Steroplast and hosted by Basrat. Really excited for this evening's webinar. Thank you for joining us. We've got professions from the whole plethora of MSK. We've got sports rehab, physio, osteos, chiros, sports therapists, doctors, and we've got international representation as always. So many of you from the US, Canada, around Europe, Asia. So thank you very much for your support and giving up your time this afternoon, this evening, this morning, wherever you are in the world. Some housekeeping before we get going. Please do feel free to introduce yourself in the chat box. We'd love to know where you're from and what you do. The recording will be made available following the event. So that's just to save me some emails. You'll get a link, a private link to the recording, and we will send you your CPD certificates of attendance to those that have joined you live this evening. If you are watching this on a recording, unfortunately, we won't be able to provide you with a certificate of attendance. Len's presentation will be around 30 to 40 minutes. We will have a Q&A. We'll do that at the end. And if you'd like to post any questions, you should see the Q&A button on your menu bar. You can post your questions in there, and please review the ones that have already been posted. You can upvote them, and we will be taking the questions in popularity order once we reach the end. A little bit about Basrat. We're the professional association and regulator for sport rehabilitators in the UK. We host these events regularly, both in partnership with Steroplast and by ourselves. You can support our work, if you like, by joining as an associate member and get access to the benefits that you can see on your screen there. I will now hand it over to Andrew, being a Steroplast event. He'll give a little bit of an introduction to Steroplast, and then we'll introduce our guest speaker, Len Funk, and get our webinar underway. Andrew.
Thanks, Ollie. Hi, everyone. Great to see so many people joining the session, and really pleased that Len's kindly been able to join us. So looking forward to hearing from Len this evening. So just a quick introduction to Steroplast. We've got over 25 years experience in the medical or healthcare sector, and we work across 7 sectors, including sport. So I lead on our work in sport, where we work in partnership with a whole range of teams, organisations, national governing bodies, sports organisations, and sports rehabilitators and professionals that are involved in sport. So really our range of products and our support extends to all of the consumables that those professionals might need and those organisations might need to help with prevention and treatment of sports injuries. With the Injury Rehab Network, we started the group in 2019 as a local group for professionals and partners based in the Northwest. And the aim was to provide a forum for those partners to collaborate around sports injuries and helping to get local communities moving, really. And the events were initially face-to-face and provided the opportunity with an expert guest speaker and some collaboration. And the events have gradually grown, and we've been really pleased to be working with Basrat. And particularly during lockdown, it's enabled us to bring these events to a wider audience and an international audience. And we've been grateful for the support of some really high quality speakers such as Len. And you can see there some of the other speakers that we have lined up for the events this year. And we're also working on plans for events beyond September too. So the next event with Diane Riding from Manchester United Academy will be focused on paediatric sports injuries, and we'll be circulating details soon around how you can register and get involved in that. And as these events have been filling up quickly, please do keep an eye out and get involved when you do. But I won't say any more about Len. Let Len introduce himself, and yeah, I hope you enjoy Len's talk. And thanks very much again, Len. Hand over to you.
Right. Thank you very much, Andrew, and thank you very much to Basrat for inviting me and including me on this. I'm going to talk about the athlete's shoulder, and what I want to do, rather than show you loads of surgery, bore you with gory videos. I want to just speak to you about the common types of athletes that I see, and the commonest injuries, really to try and contrast between the different types of athletes. So I hail from the northwest of the UK, and are very fortunate to work at one of the specialist orthopedic hospitals in the UK, Wrightington, which is in the beautiful Lancashire countryside. We have one of the largest upper limb units in the country. I think the largest upper limb unit in the country, and that's our consultants at the bottom there. Unfortunately, John Stanley, who's our leader and set up the upper limb unit, recently passed away, but we always have him and Sir John Charnley on the top right, always looking down at us and leading us. A little plug for our book. Hopefully this should be of some use to you. It's very recently published. There's also sports injuries of the elbow and hand and wrist from us. So a lot of the stuff I cover here is all in that book and more. And I see you've got Ian Horsley talking. He did our rehab chapter for that book. So if we look at the shoulder, if we start from the outside and move our way in, you have the large muscle groups, and these are the movers, not the shakers. These are the movers of the shoulder. These are your pecs, deltoids, lat dorsi, big muscle groups, and all the scapular big muscles that help move the shoulder, your rhomboids, trapezius. Then we go to the deeper muscles, and these are the shakers. These are the stabilizers, and these are the fine motor control of the shoulder. So these are your rotator cuff muscles that control the shoulder and allow the movers to move the shoulder. Now there's 30 muscles directly linked in the shoulder complex, and they all have to move in perfect harmony to allow the arm to move. And the shoulder only has one role in life, and my hand surgeons love that because it has one role, and that's to position the hand in space. We have no other role than to serve the hand. So we go deeper, and then we have the important glenohumeral ligaments, and this is showing you that the inferior glenohumeral ligament complex is like a hammock. And when you externally rotate, you tighten the front, the anterior band, and internally rotate, you tighten the back. So again, it's a well-worked mechanism for stabilizing an unstable joint. You then go deeper and you have the labrum, which is like the meniscus of the knee. It makes the glenoid cavity more concave and provides a bit more congruency to the joint. It's highly variable structure, but it does have well-defined attachments, and we'll run into that. That's important in injuries. So if we look at the labrum, we define it like a clock, whether it's right or left. Anterior is 3 o'clock, posterior is 9 o'clock, and 12 o'clock superior. The anterior inferior between 3 and 6, okay, is always well attached. And if you get a tear there, it's called a Bankart tear. At the back, it's always well attached. If you get a tear there, it's called a reverse Bankart. And the superior is called a SLAP, or superior labral anteroposterior tear. Between 12 and 3 o'clock, it's not well attached, and therefore, if it is detached in that area, it's not necessarily a tear, it's not likely to be a tear, and you shouldn't be repairing the labrum in that area. So this shows you the common injury patterns that we see within the glenohumeral joint. So you see the SLAP tears, Bankart tears, sometimes bone is knocked off and it's a bony Bankart, your reverse Bankart on the left, and a Hagel is a humeral avulsion glenohumeral ligament. This is where the capsule tears off the humeral attachment, and then you get rotator cuff tears. So we'll look at these three common injury groups, oversimplifying things, but these are the common injury groups. And I think they're important because if you look at popularity, football is by far and away the most popular, followed by rugby union and then overhead sports. If I look at my practice over a 2-3 year period, by far and away the most common athletes I see are rugby, followed by football, so your contact collision athletes, and then I see motorsports and cycling, and then overhead athletes after that, because you rehabilitators manage those chronic ones very well. So in terms of rugby, which is the most common we see, we recognize that the injury patterns have got worse over the years because guys are getting bigger, stronger, faster. And what we're seeing now, which we've just published, is the severity of the injuries in adolescent rugby players. We're seeing injuries in adolescent rugby players that we only saw in adults 10 years ago. And in adults, we're seeing injuries that are equivalent to small car accidents. So you've seen this. These are the common injury patterns. In terms of trying to determine those injury patterns, we did a study looking at a video analysis study looking at the common injury patterns. And we found that common injuries were with the tri-scorer. And this group, they got Bankart tears, slaps, and rotator cuff. Specifically, rotator cuff tears was unique to that group. In the tackler injuries, which is the commonest injury, you saw significant anterior tears, so Hagel tears and Bankart tears. The direct impact is a fall directly onto the shoulder, and we saw complex array of injuries and bony injuries as well. And the flex fall, which I originally saw only in rugby league 15 years ago, but we see it in union now, is you get the posterior injuries, the injuries at the back of the joint. So I'll just show you an examination here for showing the anterior signs. So we'll come to those. These are the signs I look for, and they can be quite subtle, particularly in a muscular athlete. So if you look at this guy here, we bring him into anterior apprehension, and you look for that wink of apprehension. You'll see that little wink of apprehension. Doesn't have significant, but that little wink. And then the other test I like is this, the anterior inferior apprehension sulcus sign. And what looking for here is there's his wink of apprehension. So, and it's the apprehension, not the sulcus, that we're looking for. Okay. In posterior, there's again a number of subtle tests. So the big ones that surgeons typically learn classically, you don't find with rugby players. So you find these more subtle signs. So they get pain at the back of their shoulder when you bring them into hyperabduction, external rotation, positive posterior load test, and then a positive Kim's test. They feel the pain at the back of the shoulder with those tests. Then the other test that I found was when doing an O'Brien's test, that the patient, a big muscular guy, couldn't even maintain his arm in internal rotation and adduction. So it just falls down. He can't maintain it there. And that's because of the humeral head translating posteriorly on internal rotation and defunctioning the posterior cuff. So a common question is what scans to do and when. You usually want to see fluid in the joint to unmask any labral pathologies and enhance them. So in less than 48 hours after a dislocation, you should have blood in the joint and a fusion, so you don't need an arthrogram, you don't need the dye. after 48 hours, probably an arthrogram is a better investigation to unmask any labral pathologies. But as MRI scans have increased in their ability to show lot better visualization, we're now moving to plain MRs more, especially where we're looking for big lesions. So for more subtle lesions, I tend to get an MR arthrogram. If I'm looking for more bigger lesions, an MRI will be adequate. CT arthrograms I do if they've had previous surgery, because you'll get artifact from previous surgery on the MRI scan. Remember the most important thing, do not rely on scan reports. Do not rely on the scan alone. Treat the man, not the scan. Also, with athletes, there could be chronic lesions, there could be acute lesions. So a very experienced sports radiologist and surgeon work in sports would be able to have a better idea of what's acute and what's chronic and what signs to look for. So what I like to do is divide the lesions up into the major lesions and the minor lesions. So the major lesions are those which we know have high recurrences or they struggle to get back to play. So these are bony Bankart's ELPSA, which is a Bankart tear where it's healed around the corner or flipped around the corner of the glenoid. That stands for an anterior labral periosteal sleeve avulsion. Rotator cuff tears, and Hagel, which is a humeral avulsion, the glenohumeral ligand. Those are big major lesions. The minor lesions are small undisplaced labral tears and partial cuff tears. So why is that important? It helps me in my decision making. So when would I go for early surgery in a collision athlete? Well, early surgery would be if they have large structural lesions with a high risk of recurrence. Generally, if they towards the end of the season and they've got time to then rehabilitate and recover after surgery before returning to play, or if they're struggling to return to play. So normally 2 weeks, no response, we need to think about doing something earlier. Those that we'd rehab and return, those with minor lesions, they're recovering well within a couple of weeks and earlier in the season, and try and get them through the season. Most of the surgeries are direct repairs. Most of them are arthroscopic or keyhole. We tend to do open repairs often for revision surgery or for bony reconstructions, either on the glenoid side or humeral side. In terms of the rehab, I'm very grateful to a number of rugby therapists over the years who've helped me develop these. And the key is it's not accelerated. Don't accelerate the rehab. Don't do aggressive rehab. It's got to be tailored to that player, to that patient, to the type of surgery they've had, to the implants that are used, and to their demands and their therapists. It's not time specific, it's goal led. So we guide them through phased period of recovery rather than time-based recovery. And each phase is introduced progressively as they pass set goals. I like this from Crichton, which looks at evaluating return to play, and it shows there's multiple factors involved, and it's a multidisciplinary decision when they return to play. So what's interesting in football is over the years, again, we've seen a lot more shoulder injuries in football. It was a small number, it's increasing, but shoulder injuries in football lead to the longest period away from play, even more than the lower limb injuries. And this was a study from 2009 by Estrand, which basically showed that the most common hip and groin was not as long a period off play as shoulder injuries. Also, we looked at the incidence over time as a number of years ago, but that graph has gone up exponentially, and you've seen that in the way footballers play. And we looked at the injury patterns in football, and the highest, the commonest was Bankart tears, 6% bony Bankart tears, large number of posterior labral tears, almost 20%, lot of slap tears, and look at that difference, 50% rotator cuff tears in goalkeepers versus 12% in outfield players. And again, a higher proportion of Hagel tears compared to a normal population. A normal incidence of Hagel's is less than 6%, so it's almost double in footballers. We looked at the injury patterns, and as you can see, rotator cuff tears are far more common in goalkeepers, and one of the studies we're doing is looking at asymptomatic goalkeepers over time. The rotator cuffs look like old people's cuffs. So in terms of treatment for these rotator cuffs, it can be difficult. Rehab, injections. When they develop partial cuff tears, you can look at some biological therapies or a debridement or a repair. If they have a full thickness rotator cuff tear, an arthroscopic repair is the best option. Sorry, that we've got some slides that have snuck in here somehow. I'm sorry about that. No, I was gonna, so move on to overhead athletes. So looking at the injury patterns in overhead athletes, and although the sports are different, they share very common injury patterns, and that's due to the repetitive overhead nature of their sport. We need to look here very much at the static and the dynamic stabilizers of the shoulder joint. So the static stabilizers lead to more humeral translation with micro instability within the glenohumeral joint. The dynamics, the stabilizer effectors are your kinetic chain, your proprioception, your scapular control, and then your shoulder accelerators and decelerators. The area surgically that we focus more on is those static stabilizers, and we talked about the inferior glenohumeral ligament and how that works as a hammock with the balanced bands anteriorly and posteriorly, with the anterior band tightening when you go into abduction or initiating throw position and loosening at the back. And what can happen with repetitive throwing motions, you can get stretching of the anterior capsule and the anterior band, which leads to a micro instability and an impingement at the back of the glenoid and humeral head. On the rotator cuff side, that can lead to partial thickness rotator cuff tears, undersurface tears, and this is, you see what it looks like at arthroscopy, these undersurface partial tears. On the glenoid side, you get this torsional effect on the long head of biceps, as well as a direct impingement and a peel back mechanism. So you then end up with chronic posterior superior labral tearing, then, you know, the type of slap tears. This is a video looking from the back of the shoulder, and you see on the left the labrum peeling back as the arm goes into full abduction and external rotation. This was in a javelin thrower, and you get that peel back. And then we can see we can lift that labrum off. That wouldn't be normal for a 20-year-old. So what we look at clinically is there anterior laxity without any true instability, so they don't complain of dislocations truly, but they have a differential laxity. The GERD sign, which is posterior tightness. We know now that it's not purely capsular, it's a lot more complex than that. The tests like the O'Brien's test can be helpful. And I showed earlier hyperabduction for posterior superior labrum, or the Thrower's test, and then a Kibler's corkscrew test, and then impingement tests. So this is a video showing you this is a swimmer. You see her internal rotation abduction is almost 90 degrees on the normal side. On the abnormal side, it's almost 0 degrees. And what I'm showing there, if I don't control her scapula, it's all coming from her scapula, and her scapula is tilting forward. So the motion's not from a glenohumeral joint. This is a tennis player showing quite significant scapular dyskinesis. You see as she goes into flexion, look at the gap between her thoracic spine and her scapula is massive. And that's called Kibler's lateral slide test. So you can measure that gap. And then this is her core stability. We do like a Trendelenburg test, and for a young girl, she's got absolutely no core stability there. So those are things that we need to identify as surgeons, and we need to make sure with you or with rehabilitators and with the physios that these things are addressed, not just the small tears in the shoulder. So this is an overall looking at this complex overhead athlete's patterns. You get a capsular imbalance, you get a muscular imbalance that leads to this internal impingement, which they sometimes can live with. They may have an overreaching injury, a minor trauma fall, which then takes them from a compensated to a decompensated state with labral tears and rotator cuff tears. So, when do we look at surgery? Really here, before that, there's no real role to surgery. And again, if they're unable to play and they're not responding to rehab. So it's not everybody with a labral tear or everybody with a partial cuff tear. It's when they're unable to play, not responding to good rehab, and do not treat the scan. In terms of the type of surgeries, there's lots of different surgeries, but if you look at surgery for a chronic overhead athlete, the return to play is very low, about 30% in the baseball studies. Whereas if you're treating a traumatic tear, the return to play is significantly better, over 80%. So like I said, that's where the role for surgery comes in. I want to talk about golfers because I was very fortunate to work with the European PGA a number of years ago. And what we found is golfers are very interesting because their two shoulders do very different things. So they get different problems with either shoulder. So on the leading shoulder, we see things like particularly AC joint pain, AC joint osteolysis. But in the younger ones, because they're more hypermobile now, we're seeing posterior instability and sometimes rotator cuff tears in the older ones. But the posterior instability has been the interesting one. On the non-leading shoulders, you get in the young ones a more anterior instability, and then also in the olders, rotator cuff tears. And this is down to a number of things, and Tanya McKenzie and Lee Harrington did some very good work on this, and showed that these muscle effects of a tight pec minor and then a stretched out rhomboids and trapezius at the back contributes to these problems in the leading shoulder, which is what we're looking at. And as they progress, like the overhead athlete, but in the reverse, they start to get posterior laxity and posterior labral pathologies with the anterior superior impingement. And this is a golfer showing the difference. So he's leading shoulder on the left and his other shoulder on the right. If anything, he's got excessive on the left, which is the symptomatic side, whereas the right side is asymptomatic. So the opposite of a GERD. As I said, they can get AC joint problems with secondary impingement in the leading shoulder. So the pec major ruptures is the last one we're going to cover. So this is your strength athletes. And again, these have increased over the past 20 years. I'm quite sure you've all seen them now. 15 years ago, I got thrown out of a room for suggesting we repair them. Now I get thrown out of a room for suggesting not to repair them. They're commonly in males. Typical presentations, they get bruising down the biceps, and people often think it's a biceps injury, but it's a pec injury. It's just the bleeding tracks down there. In the late presentations, there'll be a deformity with a defect in the axilla, and they tend to have the dropped nipples appearance and swelling of the muscle. We know that non-operative treatment, they get 50% loss of adduction and flexion. So if adduction and flexion strength is important to your sport and to your job, then this is important. But if it's not, then you can manage perfectly fine. So it doesn't mean you have to operate on everyone for a loss of adduction and flexion strength. They can get cramping. We don't know the exact incidence, and they can get fatigue and obviously a deformity. The results of surgery, a number of studies have shown, are significantly better than non-operative, but with operative, you do have a risk of complications, so risk of infection, a risk of bleeding problems, nerve injuries, and if you get an infection or any of the major complications, you could end up worse off. It's not an operation for cosmesis, it's an operation to improve function and strength. Most of the times you can get a direct repair, but to the humerus. In some cases, we may use an allograft to reconstruct or bridge that gap to allow that strength back. So I've briefly gone over our contact, overhead athlete, and strength with the common injuries. I've not covered all the shoulder injuries because there's loads. Thank you very much. And I think we came in at 30 minutes, so we should have more time for questions. Thank you.
Thank you, Len. Yeah, loads of time for questions. Very good timing on that one, and we've got the questions coming in. I would just say to everyone that's with us, if you do have questions following the presentation, now is the time to post them. Have a read through what's already there and upvote some of them. I'm going to be a little bit selfish and jump in with one of my own first that came up when we were discussing contact athletes right at the start, Len. And you noted in particular the increase in prevalence in rugby union of contact injuries, and I wondered to what do you think drives that? Is it the physical characteristics of rugby union players changing over the years, or is it changes in the tactics of the game, or something else?
Multifactorial. They're bigger, they're faster, they're stronger, they're playing more frequently, they fatigue. In the younger age groups, the variability in size is so significant, and you match that with the speed and the demands placed on younger adolescent guys now compared to before. We've seen a change in injury patterns. So, for example, you know, rugby union players have started to take on some of the tackling that's done in league. So we've seen, I used to see those complex, severe injuries only in league players when I came up north. It was quite exciting. But now we're seeing those injuries in union players as well. In addition to that, there's a higher demand on them being really strong, and they've got to train like power lifters and weight trainers. So for example, AC joint dislocations in the past that could be managed non-operatively because they can play rugby with an AC dislocation. The problem is now they can't do the weight training that they need to do to have the bulk to be able to play rugby. And then again, pec injuries, you know, we could manage them non-operatively. In the past, rugby players could play rugby with a ruptured pec fine, and some could still, but unfortunately they end up having problems with the weight training and the bulking up and the strength training they have to do to play rugby. So yeah, that's a summary. There's more to it than that. It's quite a lot of work done on that. Proprioception. Have a look at Ian Horsley's work on proprioception as well.
I know Ian's done a lot of work on that. I don't want to draw you into anything too political on the youth sport front, but I know that different countries have different models for youth sport where sort of size matching is a thing rather than age group matching. Would you advocate for that from a surgeon's perspective?
I don't know. I mean, it's the simple answer. I really don't know.
Just interesting.
I think it would be interesting to look at, you know, if they are doing that, to like rugby union does here. They're very good. They have a fantastic injury monitoring system in this country. So it would be interesting if another country does size matching and they have the same data. That would be very interesting. There's a stud for someone.
Yeah, not for me. Right, let's get to the
Not me.
Let's get to the participant questions. So the first one, most popular, and Declan, you might have to just chip in a bit extra on the chat because there's not too much detail in your question, but it's around scapular dyskinesis. So are there any, I mean, his specific question as it's posted is, what's your success been like with scapular dyskinesis? Would you ever do surgical interventions for this? For instance, if there's been injury to the nerve?
Oh, hang on. Well, that's a different thing. So you're opening. Sorry, my dog always comes in when I'm doing any zooming. He's distracting. So yeah, a couple of things there. So scapular dyskinesis, we've got to be careful. I wouldn't cause a nerve problem with the scapular dyskinesis itself. Dyskinesis, coined by Ben Kibler, just means an abnormal patterning. And we know now from subsequent studies that there is no normal patterning. So we've got to be really careful with scapular dyskinesis. And my physio, Julia Walton, if she's on here, hates me using the term scapular dyskinesis. So I think it's a minefield. So if you're talking about nerve injuries to the scapula, that when would you do surgery for that? First, you got to define what the nerve injury is, and if it's an isolated nerve injury and it's not settling, and your EMGs show that there is poor recovery of the nerve, then I would definitely refer them to my colleague who's a peripheral nerve surgeon, and he would then often do a neurolysis, or if it was that terrible, a grafting. But we've had very, very good results with early neurolysis, especially in athletes. So I would tend to refer them for that sort of surgery early. Very rare. Nowadays, I very rarely do tendon transfers anymore because most of our patients, we manage the nerves.
Yeah, brilliant. Thank you. Danny asked a
Sorry,
question.
The cat's here now.
You got cat and a dog and they're getting on.
Sorry.
What dog
Sorry.
have you got? Just to go slightly off track.
German Shepherd.
Oh,
Little
awesome.
rescue thing. Yeah.
Danny's got a question, golf related, and he posted it before we got to golfers. So it's a little bit of a case study. He's got a 56-year-old postman who's also an amateur golfer, anterior shoulder pain, particularly in the abduction external rotation position. Ultrasound scan has identified chronic subscap tendinopathy. Pain is under control. He's improving with the rehab plan that Danny's doing with him, and there's a plan in place for his progression. But do you have any tips or specific advice for this kind of injury in golfers with regards to rehab?
It's hard to know what the problem is, but if he's doing okay and he's managing with rehab, absolutely stay away from a surgeon. I mean, any chronic middle-aged shoulder pain that's atraumatic, and we see lots of people doing sports in their 50s, 60s, 70s. I've had an 81-year-old matador and a rollerblader in his 80s. So it's about managing it and not letting it get to the stage where he develops night pain. So activity modifications, managing it with the right rehab. The worst thing you can do is start pushing painful exercises, stretching, forcing. It's all about managing these types of patients, really, and keep them doing their sport. The time to get a surgeon involved will be when they've got night pain, they can't manage, they can't cope, they're unable to play. In talking about the pathology in that patient, 57, 58-year-old is going to have a tendinopathic tendons. So that's normal, age-related. As I say, the commonest I see is AC joint problems in males in their 50s, golfers. They get chronic AC joint problems.
Brilliant. Thank you very much. Next question is Gabor from Hungary. Physio, cool. Gabor, thank you for joining us. Are there any effective injury prevention programs for the athlete's shoulder that you would recommend? I guess sport comes into that.
That's not my area of expertise, to be honest with you. And I think it would be really silly of me to go down that route because it's massive. I mean, huge. Oliver's probably the one to ask that to. Oliver?
I would defer to Ian Horsley or Lee Harrington in our part of the world, I think, on that issue. And maybe another plug for the book and Ian's chapter on that note.
And I think the injury prevention for an adolescent, a young adolescent overhead athlete, and I saw you've got Angie Jackson talking, so that's her expertise, will be those young adolescent. It's going to be very different to injury prevention for a power lifter in his 30s or the golfer. So, I think it really, you need to go to the people who work within those particular sports. And particularly the cricketing physios and the cricketing S&C coaches that I work with in this country are phenomenal at injury prevention in cricketers, which is great because it means the only ones that I see are the really traumatic ones. I don't see, like in America, the American surgeons end up having to deal with a lot of these chronic throwing shoulders.
Yeah, a lot from baseball.
Exactly.
Pete's got a great question on pec major grafts. What source would you use for the graft?
Well, I've used Tendo Achilles allograft since 2006 and been very happy with that. The difficulty more is choosing the patient. The surgery's technically the easy bit, you know, that's paint by numbers. The hardest part with PEG majors is choosing the right patients, because the right patients, and the really key, is the chronic one who is a fireman, a builder, policeman, who needs that strength and adduction and flexion, and is struggling to do their job and their work, and they've got pain and they've got cramping at the end of the day. Those are the patients that are the happiest and do really well. Your worst patients for this are, again, your metrosexual, crossfitters, who, and this is the extreme, who are an accountant by day and are a mirror training gym goer by evening, and they get a PEG major. That sort of patient will not be happy, because the cosmesis is not perfect afterwards.
Well,
But it's sometimes hard to work out that gray area with those patients. So in terms of the graft choices, that's the easy bit. You know, I use tender Achilles allograft. Other people use autograft, so they use the patient's own hamstrings, or fascia lata, or they use allograft from tender Achilles. And I don't think it matters too much which graft you use. I think we don't really use synthetics. We prefer a proper biology.
yeah, brilliant. Sarah's got quite a long question, but another case study. So obviously, I know you won't be able to comment too much on the specifics of individual cases, but interesting presentation nonetheless. She's got a semi-pro rugby player with a PEG major rupture at the clavicular head. 10 weeks on, he's still got swelling. Getting better, but doesn't feel great. Has had an MRI, which now appears to show a sternal pec tear with edema. Orthopedics don't know what to do at this stage. What are the chances that he's going to get back to his sport? And do you think surgical intervention would help? Or should we just treat and rehab?
So we know that, again, from studies generally at the moment, that the outcomes of an earlier repair are generally better than a late repair. Certainly earlier surgery is easier. He's already 10 weeks now. He's already heading towards chronic. Like I said earlier, he may manage with rugby. He may not, but he generally, what we find is he's going to struggle with the weight training and the things he needs to do to be able to be competitive as a semi-pro rugby player. I mean, most shoulder surgeons would be comfortable dealing with this nowadays. So I assume he's not seen a specialist shoulder orthopedic surgeon. I recommend you get him to one as soon as possible.
Are you volunteering now, Len?
If she's in my area,
yeah,
I'm happy to see. But I mean, there's lots of good shoulder surgeons in every major city and NHS trust.
Question here from Glenn, and again, Glenn Bergeron, good friend of ours. We jumping slightly more over to the rehab side for this one, but we'll pose this anyway. So what role do you feel eccentric training has for rotator cuff, particularly in throwing sports, to accommodate for the deceleration phase of throwing?
All I can say is I know it's popular at the moment. Surgeries like rehab, their fashions come and go. So I know that's a fashion at the moment. I don't know anything about the research or the evidence behind it, but I can tell you there'll be a new fashion in 5 years' time.
Certainly will. Another potentially fashionable, potentially controversial question around steroid injections. Your opinion on steroid injections for the management of chronic shoulder pain?
Oh, they had to add the chronic.
I know, I
to
thought that.
really-
I thought that when I read it.
It was all going okay until you said chronic. Yeah, great question. I mean, it's very simple. A steroid injection is purely a very strong anti-inflammatory. If that patient has acute inflammation and you need to settle that inflammation down to allow and to assist the rehab, that's where steroid injection comes in. A steroid injection has no role to play in chronic tendinopathy. There's no role to play in chronic pain per se. It is it's an anti-inflammatory. If a really strong anti-inflammatory is what you need, then you do a steroid injection. So, you've got to ask, what does this patient need at this time? Is the problem inflammatory pain? And do we need to settle that inflammatory pain? Then it comes in. Yeah.
And,
It's as simple as that.
Through where you have determined that a patient is suitable for an injection, how many injections would you consider for the management of that patient before you start looking at progressing on to surgery?
Brilliant. Yeah, brilliant question. I mean, exactly, there's no rule. You got to balance, that repeated steroid injections has proteolytic effect. We don't know what dose and we don't know how frequent, but we know that repeated. So for example, let's say an AC joint is the commonest I see. If a guy has a good response to AC joint injection and he comes back with pain and he can't work within a few weeks, then probably we discuss surgery after the one injection. Whereas if he comes back a year later and he said, I've been great for a year, but it's flared up again now, then definitely another steroid injection. And then there'd be a gray area in between. So it's not a fixed number. It's not a fixed time. And it's also different when you're injecting a fibrocartilaginous joint like the AC joint, or you're injecting around a tendon like the long-headed biceps. You'd have a lower tolerance, or you'd have a higher tolerance to repeated steroid injections around the long-headed biceps than you would into an AC joint.
Brilliant.
So it's understanding what you're doing and why.
Yeah, absolutely. I'm conscious of the time. We'll do one more question, but there are so many. Guys,
well, I'm glad I finished a bit earlier. I could have done 20 minutes.
Oh, we wouldn't have got enough of the presentation, I don't think. What I will do is I've got some closing slides and I'll put your Twitter handle on there, so I'll share that with everybody. And guys that have got follow-up questions that we haven't been able to cover can, unless you prefer them somewhere else.
They can no, that's fine, or email me, whatever.
Yeah, brilliant, and we'll share those details. So Matt Stevens, great question. With interventions in young rugby players, so we're talking surgical versus non-surgical interventions, with dislocations and instability, what's the criteria for deciding when surgery is appropriate in youth athletes?
So, I mean, I did cover that. So there's the patient factors, there's the pathology factors, and there's the participation factors. So, in younger males, when a higher level of sport and doing contact or collision sport, they've got a higher risk of recurrence. If they have more significant, the major injuries, like the bony Bankard's Haggles rotator cuff tears, they have a higher risk of recurrence. So you'd have a lower tolerance towards surgery in somebody like that. On the other extreme, an older athlete who has more minor injuries and mid-season, you'd have a lower tolerance towards surgery.
Excellent. And we'll leave the questions there because I do want to wrap up on time, and I don't want to steal more than an hour from you.
Gosh. impressed with all the questions. I wish I'd finished sooner. Yeah.
Yeah,
That's
we've got lots, so really would encourage people to
Wow.
to follow up. I'm just gonna throw these slides up just to finish off. There we go. So I hope you all enjoyed Len's presentation. I know I certainly did. We will share details, so we'll share the recording, and you can use that to then follow up on any future resources. Obviously, Len shared the book with you at the start, which will cover a lot of the questions that I suspect you've all got. So I'd refer you towards that. And of course, you can see Len's Twitter handle there, the Shoulder Doc, and we'll share his email with you. Very kindly offered to do that for those of you that do have follow-up questions. As always, we will send you a follow-up email with your certificates for this evening and the links. If you could take 2 minutes to complete the survey that you'll be automatically directed to at the end of the webinar, we'd really appreciate it, because we use your feedback to help improve our future events in terms of logistics and everything else. So your feedback is really valuable to us. And if you'd like to support Basrat, we'd love to have you as an associate member. And if anyone has any questions on that, you can send them to yours truly. Andrew, any final comments, thoughts?
No, just say thanks, Ollie, and thanks so much, Len. It's a really fascinating. I think that's kind of simulated the most questions that we've ever had. So shoulder injuries are obviously an area of learning, but I think my reflection is that again, it's another really good presentation, and it highlights how sports rehabilitators and surgeons and other clinicians all need to work together to effectively help with sort of treatment, prevention and rehabilitation from injuries. So yeah, thanks, Len. It's great to see that you're working so collaboratively, and hopefully it's an opportunity for some of the people that have joined this evening to work with you and to learn, to continue to learn from you and some of the other colleagues that you mentioned. But yeah, thank you very much.
Can I just say that this is by far, I've done so many Zoom lectures, I've lost track. It's by far and away the best audience ever. I mean, the best amount of questions and comments I've ever seen. I'm really humbled. Thank you to your audience. Wow.
Oh, that's great to hear. And there's loads of really nice
Well
comments
done.
in the chat. Everybody's really appreciated your time this evening and thanks you for it, which is great to see.
Well done, Oliver and Andrew.
I'll take no credit for the caliber of the audience. It's solely on them.
Are they all just Andrew? I've seen him typing away madly. I think they're all Andrew.
He's logged in on 4 different devices. We will all get kicked out fairly abruptly when I do bring us to an end. So I'll say thank you once again. We will end the webinar there, and I'm sure people will follow up with you with their questions, Len. And
right.
we look forward to welcoming you back to an event in the future.
Thank you very much. And Andrew will have to tell us what's on that bookshelf.
I'm in the playroom. It's Lego.
Good stuff. Right.
Okay. Thanks a lot.
We'll wrap up there. Thank you, Len. Thanks, Andrew. Yes. And we'll see everyone soon.
Bye.